It's a pleasure to be with you. The title of this talk is Maternal Immunizations. There are no disclosures for this presentation. Objectives include review the immune challenges of mothers and newborns, review basic concepts of placental transport of IgG, understand the timing rationale for inactivated influenza vaccine, IIV and Tdap in pregnancy, review the impact of IIV and Tdap vaccination on pregnancy and newborn outcomes, understand the barriers to vaccinations in pregnancy, and review the American College of Obstetricians and Gynecologists, ACOG, clinical guidelines for maternal vaccinations. Both mothers and babies have immune challenges related to susceptibility to vaccine-preventable diseases and response to vaccinations. Pregnant women have a blunted immune response, therefore making them at greater risk for vaccine-preventable diseases and serious complications and death. Neonates and infants have immature immune systems, limiting their response to vaccines, leaving them vulnerable for months while awaiting immune maturation and response to their primary vaccination series. It often requires multiple doses of vaccines to achieve protection, therefore leaving the infant at risk of disease while awaiting an appropriate immune response. In these situations, placental immune transfers from mother to baby protect the infant, underlining the importance of maternal vaccination in not only protecting the mother, but also the baby, the two-for-one strategy. Maternal immunization is not a new concept. In 1879, vaccinia vaccination of women was used to protect the neonate against smallpox. From 1938 to 1940, whole cell pertussis vaccine was used to protect the newborn from whooping cough. In 1961, tetanus vaccine was used to prevent neonatal tetanus, particularly in resource-poor nations. This vaccination strategy saved the lives of millions of mothers and infants. In 1964, the first United States maternal influenza vaccine was recommended. Despite the benefits for both mother and baby, there are several challenges for maternal vaccinations. In many developed countries, there are misconceptions about the risks and benefits. Many patients, including healthcare providers, have never seen the devastation of vaccine-preventable diseases and often feel the risk of vaccination outstrips potential benefits. This lack of awareness about vaccine-preventable diseases in patients and providers is one of the largest barriers to maternal vaccinations. The public is aware of other medication tragedies harmful to the fetus, like thalidomide. Thalidomide was developed in 1957 in Germany and used to treat morning sickness. Thalidomide was teratogenic, causing a condition called phocomelia in fetuses and neonates, resulting in babies being born without limbs. Over 10,000 children were affected in the 1950s and 60s. Medication tragedies like thalidomide impact the public's perception of any medication use in pregnancy, including maternal immunizations. The misinformation on social media, enhanced by vocal anti-vaccine celebrities, has also had a negative impact on all vaccination programs, including those for pregnant women. There are challenges with the paucity of FDA licensing pathways for maternal vaccinations in the United States. Manufacturers express liability concerns despite the presence of the National Vaccine Compensation Program that covers the liability of vaccine-associated injuries for mothers and fetuses. Another challenge is that historically, obstetric providers were not trained to vaccinate and often feel uncomfortable providing that service in their clinics. There is also a perception among providers that pregnant women are unwilling to get vaccinations. There are also concerns about the extra time it would take in the clinic to educate, handle, and store the vaccines, vaccinate, and bill for reimbursement. In developing and even developed countries, distrust of government and cultural barriers are a challenge and seem to be increasing. Despite the multiple medical contacts during pregnancy, there is currently no standardized maternal immunization platform for obstetric care. Let's briefly discuss placental transport of immunoglobulins, or IgG antibodies, which are of major interest in maternal-fetal immune interactions and informs maternal immunization strategies. 60 to 70% of immunoglobulin G in the bloodstream is IgG1, followed by 20 to 30% IgG2, 5 to 8% IgG3, and 1 to 3% IgG4. The amount of the different IgG subclasses present in the bloodstream varies with age. IgG1 and IgG3 reach normal adult levels by 5 to 7 years of age. IgG2 and IgG4 levels rise more slowly, reaching adult levels at about 10 years of age. In young children, the ability to make IgG2 antibodies to the polysaccharide coatings of bacteria develops more slowly than the ability to make antibodies to proteins. Not all IgGs are equally transported by the placenta from mother to the fetus. IgG1 and IgG3 are transported much better than IgG2 and IgG4. IgG1 and IgG3 are stimulated by various non-polysaccharide antigens, including various proteins used in conjugated vaccines. This was shown when comparing immune responses to pneumococcal polysaccharide vaccine versus the pneumococcal protein conjugate vaccine, showing increased IgG1 in the conjugate vaccine group. IgG2 production is stimulated by polysaccharide vaccines. Therefore, the non-polysaccharide vaccines, including conjugate vaccines, will have greater transfer of protection for the baby than the straight polysaccharide vaccines. Placental transport via receptor mediation starts at 17 weeks gestation. By 33 weeks, maternal and fetal levels of antibodies are equivalent, representing passive transfer. By 40 weeks gestation, active transfer of antibody kicks in, resulting in fetal antibody levels higher than those in the mother. Various conditions inhibit placental transfer, like HIV and malaria infections, also including other etiologies causing chorioamnionitis. This slide is adapted from a New England Journal of Medicine article in 2001. As mentioned previously, when a mother has IgG1 and IgG3 antibodies in her serum, placental transport starts at 17 weeks gestation and progressively increases, with maternal levels equaling fetal levels at 33 weeks, passive transport. By 40 weeks, fetal levels are greater than maternal levels, active transport. That IgG1 and IgG3 maternal antibody transferred to the baby provides significant protection against organisms for which the mother has immunity and lasts well into the first year of life, while awaiting the building of the infant's own immunity in response to their primary vaccination series, the protection triangle. Without that transferred immunity, that same triangle becomes a vulnerability triangle. This underlines the importance of vaccinating the mother to protect the infant. This slide lists important questions to consider related to maternal immunization strategies. Safety of mother and infant. immunogenicity of the vaccine in the mother, placental transfer. What type of immunity does the vaccine stimulate in the mother, and how effectively is this immunity transported to the baby? Polysaccharide-only vaccines primarily stimulate IgG2 that isn't transported as well across the placenta, where non-polysaccharide vaccines, including those with protein conjugates, stimulate IgG1 and IgG3 that are transported more effectively, resulting in a better triangle of protection. Timing is also important and depends on the target. For influenza, protection of the mother is primary, resulting in recommendations to immunize as early in pregnancy as possible. For pertussis, the prime target is to protect the baby more than the mother. Therefore, the preferred time to immunize is 27 to 36 weeks gestation, a peak time for maximal antibody placental transfer. This is a generic antibody response slide and helps illustrate why immunizing the mother at 27 to 36 weeks during the third trimester makes sense. The mother's IgG antibody response after immunization may peak somewhere between 2 to 5 weeks after immunization, then slowly declines. As previously mentioned, the peak placental transfer of antibody between the mother and baby occurs at 33 to 40 weeks gestational age. If we immunize the mom, for example, with Tdap at 27 to 36 weeks, we should have the best chance of transferring the most pertussis antibody to the baby. There are 3 vaccines regularly recommended for pregnancy: inactivated influenza vaccine, IIV, pertussis, a component of Tdap, along with diphtheria and tetanus antigens, and tetanus, if not getting Tdap. Tdap is recommended for all pregnancies in the United States. Tetanus only would apply to situations where Tdap is not available, like resource-poor countries or when contraindicated. This includes some special vaccine recommendations, primarily when the pregnant woman is at high risk of infection, and includes having an underlying predisposing physical condition making a pregnant woman more susceptible to a vaccine-preventable disease, travel to an endemic area, exposure during an outbreak, and having an occupational or lifestyle exposure. Some more common vaccines used in special circumstances in pregnancy include hepatitis A and B, meningococcal and pneumococcal polysaccharide vaccines, and rabies vaccine. Also, when at high risk, the following vaccines are also recommended: IPV and activated polio vaccine, anthrax, Japanese encephalitis, and yellow fever vaccines. Just a few additional general comments about travel in pregnancy. Don't travel to high-risk areas when pregnant, if at all possible. Try to complete pregnancy before travel outside the United States. It's also wise to keep the baby stateside until 6 to 8 weeks old, if possible, to complete at least the first 2 immunization series. Beyond 8 weeks of age, the concern about serious infectious illness like sepsis in a febrile infant decreases. Where risk of disease is high and avoidance not possible, give yellow fever and Japanese encephalitis vaccine. Let's now consider inactivated influenza vaccine, IIV, for a few minutes. General recommendations include IIV should be given to all pregnant women during influenza season. Give at any time in pregnancy, including the first trimester. Live attenuated influenza vaccine, LAIV, should not be used in pregnancy. Yet, if LAIV is inadvertently given, there is only a theoretic but not proven risk for the fetus. There are significant influenza risks for both mothers and babies. IIV uptake in pregnancy is about 50% and has been at that level since 2009, leaving half of the pregnant women and their infants in the United States at increased risk of complications and death. There is a five-fold increased risk of complications and death in pregnant women infected during the second and third trimesters. With inadequate IgG placental transport, influenza-infected infants have an increased risk of complications. There is no infant influenza vaccine available until 6 months old, leaving the infant with inadequate protective antibodies during the first 6 months of life. Infants also require 2 doses of influenza vaccine separated by 4 weeks to build adequate protective antibodies, adding an additional 4 to 6 weeks of vulnerability for infants even if starting the vaccine series at 6 months old. Needing a second dose of influenza vaccine in infants creates a compliance issue for this group. This slide provides some additional information about influenza infection in pregnancy. Increased susceptibility to complications in pregnancy is associated with several factors, including altered respiratory capacity and decreased cellular immunity. Complications include increased hospitalizations. During the 2009 pandemic, there was a 20% death rate with hospitalization due to influenza in pregnancy. Other complications include spontaneous abortion, preterm delivery, and low birth weight infants. The last 2 slides underline the importance of immunizing the mother, not only for her protection, but also to help protect the baby during those vulnerable first 7.5 months of life, while awaiting the baby's immune response to their primary vaccine series. So is IIV safe and effective in pregnancy? A study published in the journal Vaccine in 2016 demonstrated that vaccinated women had 9.7 visits to emergency departments for acute respiratory illness complaints versus 35.5 per 10,000 person days for those not vaccinated. They also had less hospitalizations than those unvaccinated, 16.2 versus 34 per 10,000 person days. A study by Fell et al., published in the American Journal of Public Health, studied the newborn infants of 22,340 women. Infants of vaccinated women had a lower relative risk, RR, for being small for gestational age, relative risk 0.9, gestational birth at less than 32 weeks, relative risk 0.73, and fetal death, relative risk 0.66 versus infants of mothers not vaccinated with IIV. Other infant studies also demonstrated reduced prematurity by 40%, reduced influenza-related hospitalizations by 81 to 90%, and influenza-like illness, ILL, by 64%. Numerous other studies showed no increase in fetal anomalies in infants of vaccinated mothers, even those vaccinated in the first trimester. Inactivated influenza vaccine, IIV, seems very safe in pregnancy, even if given during the first trimester. Let's now consider pertussis vaccine for a few minutes. Acellular pertussis is a component of Tdap, along with tetanus and diphtheria. Tdap should be administered during each pregnancy, regardless of the history of previous Tdaps or TD vaccines. Even if pregnancies are in close proximity, the relatively rapid decline in maternal antibody underlines the importance of a Tdap vaccination with each pregnancy. Tdap should preferably be given at 27 to 36 weeks gestation for the reasons previously discussed. Give Tdap postpartum if there is a history of the mother not having received Tdap or if the vaccination history is unknown. Infant contacts, like caregivers, family members, etc., should also be up to date on pertussis vaccinations for their age and preferably completed their last pertussis vaccination at least 2 weeks prior to infant contact. These family members do not need a Tdap with each pregnancy of the mother. They just need to be up to date on pertussis immunizations for their age. This table lists the 3 stages associated with the clinical course of pertussis: catarrhal stage, paroxysmal stage, and the convalescent stage. Pertussis symptoms usually develop within 5 to 10 days after exposure, but can be as long as 21 days after exposure. Pertussis has an insidious onset with catarrhal symptoms that are indistinguishable from those of minor respiratory tract infections, with coryza having an inflamed runny nose, fever, and mild cough that worsens. The cough, which is initially intermittent, becomes paroxysmal. In typical cases of unvaccinated infected infants, paroxysms terminate with an inspiratory whoop that can induce vomiting. Paroxysms of cough, which may occur more at night, usually increase in frequency and severity as the illness progresses. The cough typically persists for 1 to 6 weeks or more. The illness is often milder and the characteristic whoop absent in vaccinated children, adolescents, and adults. After paroxysms subside, a non-paroxysmal cough can continue for 2 to 6 weeks or longer. Unvaccinated or incompletely vaccinated infants younger than 12 months of age have the highest risk for severe complications and death. In infants, the cough may be minimal or absent, and apnea may be the only symptom. Clinicians often overlook pertussis in the differential diagnosis of cough. This slide emphasizes the impact of pertussis disease on infants. Those with an incomplete primary series, less than 6 months old, have a 20-fold higher risk of pertussis disease than those fully vaccinated. Complications are most common in infants less than 6 months old. 2/3 of infections in those under 6 months of age result in hospitalization. Death is almost exclusively seen in those under 3 months old. Pertussis disease peaks epidemiologically every 3 to 5 years, as evidenced by studies from the United States, Australia, the United Kingdom, Portugal, and others. Immunity, natural and vaccine-induced, wanes relatively quickly. Therefore, most people have multiple pertussis infections throughout their lifetimes. Pertussis is highly contagious, with an infected person contagious from onset to 3 weeks after the start of the paroxysmal cough, or for a total contagious period of 4 to 5 weeks. Pertussis is often atypical, mild, or asymptomatic in adolescents and adults, and therefore, if not thought of as part of the differential diagnosis by clinicians, often goes untreated, or susceptible individuals are not provided prophylaxis. Yet these infected adults, including healthcare professionals, are often a source of infection for infants, those at risk of severe disease and death. There are 3 tests used to detect pertussis: culture, polymerase chain reaction, PCR, and serology. Culture has excellent specificity, meaning the chance that a positive test truly identifies an infected individual. There are very rarely false positive culture tests. Culture should be obtained by nasopharyngeal swab and collected during the first 2 weeks of infection. After the first 2 weeks, sensitivity or ability of the test to identify a true infection decreases and may give a false negative result. PCR is a rapid test and has excellent sensitivity, or the ability to pick up true infections. However, PCR tests vary in specificity, meaning they can result in false positive results. cultures should be done along with PCR to help with diagnosis. PCR should be performed on nasopharyngeal specimens taken at 0 to 3 weeks following cough onset. PCR may provide accurate results for up to 4 weeks. After the 4th week of cough, the amount of bacterial DNA, the target of PCR testing in the nasopharynx, rapidly diminishes, which increases the risk of obtaining false negative results. The CDC has developed a serologic assay that has been extremely useful for confirming diagnosis, especially during suspected outbreaks. Many state public health labs have included this assay as part of their testing regimen for pertussis. Commercially, there are several different serologic tests used in the United States with unproven or unknown clinical accuracy. The CDC is actively engaged in better understanding the usefulness of these commercially available assays. Generally, serologic tests are more useful for diagnosis in later phases of the disease. The optimal timing for specimen collection is 2 to 8 weeks following cough onset, when the antibody titers are at their highest. However, you may perform serology on specimens collected up to 12 weeks following cough onset. Just a few comments about treatment and prophylaxis of pertussis. The earlier a person, especially an infant, starts treatment, the better. If an infected person is treated during the first 1 to 2 weeks before coughing paroxysms initiate, symptoms may be lessened. From the previous slide, persons with pertussis are infectious from the beginning of the catarrhal stage, runny nose, sneezing, low-grade fever, symptoms of the common cold, through the 3rd week after the onset of paroxysms, multiple rapid coughs, and occasionally the classic whoop. Treatment can shorten the time an infected person is contagious for others. Generally, a patient is non-contagious 5 days after the start of effective antimicrobial treatment. Antibiotics for pertussis include erythromycin, clarithromycin, azithromycin, and trimethoprim sulfamethoxazole. For infants younger than 1 month of age, azithromycin is preferred because azithromycin has not been associated with infantile hypertrophic pyloric stenosis that has been associated with erythromycin use in that age group. Trimethoprim sulfa should only be used in those over 2 months old who may not be able to tolerate macrolides or have a resistant organism. There are limited studies of trimethoprim sulfa in the treatment or prophylaxis of pertussis. Antibiotics should be given for 5 to 14 days dependent on the antibiotic chosen. Azithromycin for 5 days seems to be the best choice in most instances. The 5-day course may encourage more compliance. Maternal immunization with Tdap has been shown through numerous studies to be safe for the mother and infant, safe when repeated doses are given, and safe when given with IIV. Maternal Tdap has been shown to be immunogenic for the mother via numerous randomized controlled trials and prospective cohort studies. It also results in significantly higher antibody levels in infants from 0 to 2 months old. Some mild interference with the infant's response to Tdap has been demonstrated, but thought to be clinically insignificant. This is a study from England and Wales reported in The Lancet in 2014. This table shows vaccine efficacy at the 95th percentile confidence interval in infants less than 2 to 3 months old, dependent on the time of maternal vaccination. There was a 90 to 91% efficacy if the mother was immunized between 7 and 28 days prepartum during the 3rd trimester versus a 38% efficacy if the vaccination was given 0 to 6 days prepartum or 1 to 13 days postpartum. So immunizing during the third trimester, but ideally not within 0 to 6 days of birth, is important. This is a study from California reported in Clinical Infectious Diseases in 2017. This once again demonstrates a better vaccine efficacy when maternal Tdap is given during the third trimester versus at other times during pregnancy. Some experts suggest that a late second trimester vaccination may be of benefit, but will not likely be as good as that given in the third trimester. Note also the drop in efficacy between 8 to 12 weeks of age as maternal antibody levels given via placental transport decline. This shows how important it is to vaccinate the mother during the third trimester, but also administer the primary vaccination series to the baby, building their own antibodies to pertussis. Maternal immunizations really work. So what are the main barriers to maternal vaccinations? Remember that only about 50% of pregnant women get IIV and Tdap in the United States. 2 studies reported the first 4 barriers to maternal vaccinations, including healthcare professionals' misperceptions. This is a misperception that pregnant women don't want to be vaccinated in pregnancy. Other barriers include no strong recommendation from OB providers, inadequate education of OB providers, and clinical practice concerns. Many OB providers lack confidence to discuss vaccinations with their patients. Other practice concerns include reimbursement issues, vaccine ordering, and storage. Studies reported in the MMWR and the journal Vaccine identified vaccine misperceptions of pregnant women as an additional barrier. The 5 most common reasons pregnant women refuse influenza vaccination include safety risks to the baby, the flu vaccine will give me the flu, I don't think the vaccine is effective, safety risks to me, and the flu is not a serious illness. Influenza infection is a risk for the mother and baby, but influenza vaccine is not. Influenza vaccine may be associated with some mild discomfort, but is not associated with the risk or complications and death like influenza disease. It's unfortunate when we use the term flu for everything from colds to food poisoning. This leaves a misperception with the public that influenza is not a very serious illness. This slide shows the priority of very important concerns women have regarding vaccinations in pregnancy. 85% are very concerned about safety for the baby, followed by 70% safety for me, 55% adequate information, 25% concerns about extra time required to get a vaccination, 15% costs, and 7% fear of shots. All of these concerns, but particularly the top 3, can be addressed as a priority in the OB provider's office. Also note that 83% of these women said they would get the vaccine if their provider recommended it. Provider recommendation is key. OB providers need to be equipped to provide appropriate vaccine information, answer patient questions, make strong recommendations to get the vaccines, and provide vaccinations, or at least refer them for vaccination. The main message OB providers need to give is maternal immunizations are safe and effective. This lists the American College of Obstetrics and Gynecology's recommendations regarding maternal immunizations. Advocate. Talk with patients directly and strongly recommend IIV and Tdap vaccines. Identify. Use paper or e-prompts to identify patients needing vaccines. educate and vaccinate, educate clinical and office staff, and immunize staff members and patients, practice what is preached, integrate, develop and implement standing orders and document immunizations in the state's immunization registry. Immunization registries are for everyone, not just children. This slide lists additional vaccines that may be part of the maternal vaccine schedule in the near future, including meningococcal and pneumococcal polysaccharide and conjugate vaccines, Group B streptococcus conjugate vaccine, Haemophilus influenza B vaccine, and respiratory syncytial virus RSV vaccine. In summary, maternal immunizations are important, IIV and Tdap. Maternal vaccinations protect the mother and baby. The American College of Obstetrics and Gynecology, ACOG, clinical guidelines need to be implemented to improve maternal vaccination rates.